Robin Gelburd. Let's welcome her to the stage. Robin, come on up. Thank you for coming out from New York City.
Oh, it's such a pleasure.
I appreciate it.
It always is
Take
to
her
come
away.
to these. Thank you. So good morning, everyone. It's such a pleasure to be here. I love the State of Reform conferences. It's like a stew of everyone in the healthcare ecosystem. And it's great to be able to come here and share with you what we're learning about Oregon in our national repository. So as DJ mentioned, Fair Health is a very unique organization. Although it was created out of an investigation that was originated in New York by the Office of the Attorney General, it was created as an independent, self-sustaining organization. I am still not aware of any other entity that was created as an independent organization from such an investigation. And essentially what we were tasked with was really to bring transparency and integrity to health insurance information. And even though it was a New York investigation, it gave rise to a national remedy. We were really required to do a number of things. One was to create a new data repository of healthcare claims that were really informed by the best thinking of statisticians and economists in the way in which we organized, aggregated, and validated the data, and to use that data to populate benchmark products as well as custom analytics to really inform all types of decision making. As a 501c3 independent not-for-profit, we were also tasked with helping federal and state policymakers and officials really work through the complex questions plaguing the healthcare system today, as well as researchers. And then finally, what was considered the crown jewel of the settlement was launching a free consumer website that gave unparalleled visibility into healthcare pricing and also tried to elevate health insurance literacy for patients and their families. We really sit right in the middle of the healthcare schoolyard, if you will, working with all the different stakeholders and really are informed by the viewpoints of all the different elements in the system. It helps inform our work and our initiatives. So first, we have the largest private claims collection in the country. Now we have over 29 billion records. That's medical and dental combined, dating back to 2002 to the present. It includes both fully insured and self-insured data. And why the self-insured is important, for those of you who followed the recent Supreme Court case coming out of Vermont in the Gobet matter, where the Supreme Court ruled that all payer claims databases are not permitted to mandate the collection of self-insured data because of an ERISA preemption. We get that data voluntarily, and it really rounds out the healthcare system for all of the stakeholders that use our data. The data comes in very currently. We get monthly feeds from over 60 contributors who are comprised of national and regional insurers and third-party administrators. That data in the aggregate represents the data experience for approximately 150 million covered lives across the country. And what we do is we break that data down into 493 distinct geographic regions so you can really capture the heartbeat of the medical market. Oregon has 5 geozips that we break out the data to in comparison to Medicare, for example, which has 2 geographic regions for Oregon. Speaking of Medicare, because of the representativeness of our data in all 50 states, CMS has certified Fair Health as a national qualified entity, which means we've been entrusted with the entire collection of Medicare Parts A, B, and D. With respect to Medicare Advantage, that's in our private collection. So this $28 billion is separate from the $29 billion commercial. Also, because of our neutrality, many states approach Fair Health to help them support their various health-related programs. So, for example, our data and benchmarks inform a number of workers' comp fee schedules, auto liability fee schedules. We're written directly into the California Healthcare Code for emergency care services. We support your neighbor, Washington State, with the Women's Wellness Program. We support Arizona with a dental program for pediatric disabled children. We work with a medical indemnity fund for neurologically impaired newborns, helping reimbursement in that case. And many of you may be following, there's been a really roiling debate across the country on surprise billing legislation. Some states have already passed laws that protect the consumer in the event of a surprise bill, typically for hospital-based services like pathology, radiology, anesthesiology, and ER. We already serve as a benchmark in 3 states, New York, Connecticut, and New Mexico, and the federal government is likewise debating this issue, and 25 other states have come to Fair Health for data cuts, and you'll see an example where they're trying to noodle through what should be the right solution for their state when it comes to reimbursing providers for those surprise services. Should they be using billed charges, negotiated amounts, what percentile, or what multiple? And likewise, in addition to the states, we support the federal government. We provide a data feed to the Bureau of Labor Statistics for their medical CPI index. The CDC just concluded a study with us on neurology disorders. We've also informed the GAO for their reports on air ambulance and so forth. We have done studies on food allergies that have been used by the USDA. All of our research is typically disseminated freely, and you can find most of it on our website. So, back to Oregon. We have this ocean of claims. It's really our responsibility to take what really would look like an opaque ocean to many, and in a sense bring you out on this glass bottom boat and let you see what we're seeing in your state, and also give you a point of reference to how you compare to some national indices in some areas that we see trending that are really creating some dramatic change in the healthcare system. So as we move into Oregon, one of the first areas I wanted to touch upon, and sometimes we feel like the canary in the coal mine from our perch, because we could see trends emerging and sort of all the pieces on the chessboard moving. One of the things that's quite dramatic, and you're probably seeing it here is where patients are choosing to get their care. There's a tremendous, in a sense, like mini revolution underway in the choice of alternative venues of care, whether it's going to retail clinics, going to urgent care centers, choosing telehealth, ambulatory surgery centers, and it's really fascinating to see where patients are electing to get their care, and it's very local in terms of what those trends are. So let's start with retail clinics, because Oregon is quite notable in this area, and just to orient you to how to understand some of the charts I'll be showing, as you can see, what we did here is we took all of the claims for the period shown, 2012 to 2018. We isolated all claims for Oregon where services were rendered with a field of services retail clinic. We arrayed that data just to see what the trend lines are, to see whether it's increasing, decreasing, or staying the same. We compared those trend lines to the national retail clinic claims. Then separately, the other thing that you'll see on the vertical axis are total medical claim lines. So not only are we tracking the trends of retail clinic usage, we're showing what the percentage of retail clinics are against the total percentage of medical claims. As you could see, Oregon is way out front in terms of the country, in terms of the increase over that period of time in retail clinics. And what you'll find with some of these alternative venues, it's often very driven by the regulatory and statutory climate in the state. So in Oregon, there is a rather restrictive permissive environment with respect to retail clinics. In some areas, you'll see restrictions on the type of healthcare professionals that can render services in the retail clinics, what services can be rendered, what age groups can be serviced. And in Oregon, there's a more liberal environment, which is reflected, as you can see. So Oregon not only exceeds the country in terms of the rate of increase, it also exceeds the country in terms of the percentage against total claim lines. Another thing I'd like to point out as we go through some of the conditions that are presenting in these alternative venues, you'll notice as we move through the different venues, you'll see a lot of repetition in the types of diagnoses presenting. What that shows is a dramatic blurring of the lines between the venues, so that you could see patients, one, may be confused about what to choose, but they're making different choices, and sometimes that's really creating its own informal triage system. So here what we did was we isolated the top 5 diagnoses presenting in Oregon to retail clinics, and as you could see, juxtaposed with the national 5. And there's some differences and some similarities. You could see that acute respiratory infections dominates both, But you could see on the national side, exposure to communicable diseases, whether you're testing for strep or flu, does not appear on the Oregon side. And you could see some of these conditions, urinary tract infection or ear infections, skin infections, are classic things that you would otherwise maybe go to a medical office for or another venue. So it's interesting to see. And now when you go to the age cohorts, you could see for the most part on the national side, it's relatively flat in terms of what the distribution is, other than over 60, which is lower than the other three. You could see a much marked difference between the 23 to 40 and the 41 to 60 age cohort in Oregon, which shows for 41 to 60 to be using retail clinics at that level. They are really turning to it as a really vibrant part of the primary care landscape here. Turning to urgent care, you could see here that Oregon again exceeds the rate of increase from 2009 to 2018 at 700, really about 725% compared to about 550% at the national level. But what's interesting here is you could see the yellow national line exceeds Oregon in terms of what percentage of the total medical claim lines it comprises, which means that even though the national rate of increase has been a little bit lower, it started at a higher rate and is already taking up a bigger part of the medical pie. In terms of the top diagnoses presenting, rather similar between the nation and Oregon, except the fact that sprains, strains, breaks, and fractures appears on the Oregon list. Not surprising, you have a gorgeous state. I went hiking yesterday in Forest Park. I could see I almost sprained myself on wet leaves. I'm sure there are a lot of those people who are presenting. So it's, again, this is part of the local reflection of what you offer. Again, what's interesting here is different distribution in Oregon than the nation in terms of urgent care usage. You could see the 0 to 22 age cohort quite notable as the highest in Oregon. And one thing that makes our life exciting at Fair Health is when we sort of go out on that ocean, whether it's on a glass bottom boat or kind of snorkeling, if we see something interesting, like a beautiful piece of coral or fish, we then start scuba diving, and we can go deeper and start looking at what's really causing that or what that was. So with the 0 to 22, it did catch our attention. So we have the ability to really isolate that cohort and really look at the array of diagnoses that are particular to that group. And again, you'll see the sprains, breaks and fractures, you'll see the head injury, other kinds of injury to the body, and other things that would not be unusual in that age group. Going to ambulatory surgery centers, these are Medicare certified ambulatory surgery centers, the most recent map issued by CMS. You could see Oregon ranking 19 with 88 ASCs, compared, for example, to Washington State that has 188, which ranks 8 on the list. ASCs now are really increasing in usage. It's been estimated that approximately 50% now of outpatient surgeries are being done at ASCs. So how does Oregon compare? You can see pretty much close to what we're seeing in the nation as a whole. And again, it's slightly above on the rate of increase with the nation and also slightly above in terms of percentage of medical claim lines. Again, the age distribution is what we see across the entire country, and that is obviously because what typically happens in an ASC would be endoscopies, colonoscopies, cataract surgeries, procedures that you would typically find in that 41 to 60 age group or over 60. What you see in the 0 to 22 age group typically are ear tubes or something of that nature. All right, let's go to ER. So ER, it's interesting. I think what we're seeing in Oregon, it has a lower rate of increase than the nation as a whole, and a dramatically lower percentage against medical claim lines. And that may be this sort of an interesting dynamic. What's happening here likely, and I'd be interested to talk to some of you in the room, I mean, there is that triage going on. You could see that, and when you look at the emergency care diagnoses, you'll see how much they are closely aligned with the urgent care. even the retail clinic diagnoses. So people are finding other outlets for their care. They're making their own decisions potentially about non-emergent care that may otherwise have been presenting in an emergency room. And other jurisdictions that may not have those other outlets are still seeing high ER utilization and would really welcome to really reduce that. In terms of the top diagnoses, really nothing unusual other than the 4 and 5 positions in the national and Oregon listings are just flipped, but pretty much the same distribution. In terms of the age, allocation across the different cohorts, this exactly mirrors what's happening around the country. So Oregon is in lockstep with the nation in terms of the ages presenting in the emergency room. Here, if you look at 0 to 22, just isolating that, you can see, again, the sprains, strains, breaks, and fractures on the list in Oregon, where you don't see it in the nation, as well as head injury and injury to the body. Exactly what you would expect in your gorgeous state. And then 23 and older, what you see adding onto the list and displacing others are cardiac events, which obviously is not as prevalent in 22 and under, and it's not unusual to see that. What is unusual is in Texas, for example, with the freestanding ERs, you don't see cardiac events in this older cohort because in freestanding ERs, they're not treating a lot of cardiac events because you really need to be tied to an inpatient facility. So it's interesting how that's really changing the landscape in Texas. Behavioral health. Some interesting facts in Oregon. As you could see, on the national side, the #1 notable diagnosis pertains to mental health disorders associated with substance use. That really appears way down on the list in Oregon, where you have adjustment disorders being the top. And I'm sure a number of you are aware in the room about the recent SAMHSA study that showed while Oregon is #4 in terms of substance use, they're ranking 50th in terms of access to certain treatment protocols. So you would not see many claims. It's not surprising then that it would rank lower. The adjustment disorders is interesting that it does outdistance the nation. And when you look at the behavioral health distribution, while the ages are the same, there's some interesting facts after that. Looking at adjustment disorders, if you isolate that, adjustment disorders being, those symptoms associated with a particular event, whether it's a loss of a loved one, an illness, a loss of a job, a divorce. Everyone has stress with those, but these are sort of persistent clinical symptoms that then give rise to such a diagnosis. There are many different categories of adjustment disorder. In Oregon, the leading one by quite a distance is adjustment disorder with both anxiety and depression. By age, again, you can see the hierarchy the same in terms of what's happening across the country. Turning to telehealth. Telehealth in some ways is like the inverse of retail clinics in Oregon, it appears. So while Oregon seems to have a large increase between 2012 and 2018, and pretty close to the 1,300% increase you're seeing in the nation, you're seeing obviously a much larger percentage of total medical claims in the nation than you see in Oregon. And that may be, again, it harkens back to what I was saying earlier about how a statutory or regulatory environment can really have a tremendous impact on utilization within a state. Oregon, as far as I understand, is not part of the Interstate Medical Licensure Compact, which does inhibit the ability of certain physicians outside of the state to service patients in the state. You also have a parity law that's interesting that applies to private payers and the government health plan, which for now, it appears it's limited to the video conferencing, which is sort of that synchronous kind of service. There's a lot of activity in telemedicine that's asynchronous that may not be captured in Oregon or not be highly utilized. As you can see here, what's interesting, mental health reasons very similar to the nation in terms of that 35%, but look at #2 in the nation, 17% for acute respiratory infections, which is really below 5% in Oregon. So again, there may be, this may be a reflection of either certain reimbursement issues or certain regulatory or statutory issues, but an interesting difference between Oregon and the nation as a whole. Here, Oregon is, again, flatter in terms of its age cohorts. To the left, you could see the nation is much more stepped in terms of the way in which the different age groupings are accessing telehealth. This is really quite dramatic. In Oregon, you could see mental health reasons being over 50% of the diagnoses associated with patients aged 0 to 22, compared to about half of that in the nation. And if you look at the number 2 diagnosis in the nation, which goes to eye infections, and also you can see skin infections on that list, those are the kinds of services that are typically done in an asynchronous manner, where someone may transmit, say, a picture of a rash, or if you think you have a stye or conjunctivitis, to a specialist, and then they are communicating with you after the fact. You don't really see a high number of those in Oregon. Again, may link back to that parity law, and it's an interesting issue that sort of invites further study. Turning now to reimbursement models, this is where Fair Health gets asked for a lot of information in connection with either the design of state laws and regulations, or looking after the fact the impact of laws and regulations, as well as at the federal level. So as I mentioned earlier, with surprise billing, using that as one example, what we're often asked to do is to present different levels of reimbursement based on either bill charges or the negotiated allowed amounts, and compare that to CMS. Sometimes people think Fair Health is a single value, because a single value may at times be implanted into a statute, but that's after a state or whatever licensee or stakeholder is looking at the data and chooses a percentile. Our benchmarks offer a 12-month window of very current data, typically from the 50th to the 95th percentile for all procedures, CPT, HCPCS, and so forth. And so really depending on what the interest is of the state or various stakeholder, they'll select which one they're interested in. So here, just to give you an example, we took the 50th percentile of bill charges for 3 different geozips in Oregon and compared it to the negotiated amount, which is the allowed 50th percentile, and comparing it to the CMS rate, just so you could see how data get arrayed. And that's for a common stitches in the emergency room. Again, with the surprise billing, we're often asked for services associated with emergency services, pathology, anesthesiology, radiology, and so forth. Turning to a moderately severe problem, sometimes we're asked to compare different geozips. Sometimes we're asked to compare a geozip to a state. So here's an example of comparing geozip 972 to Oregon as a whole. Again, both at the 50th percentile of charges, the 50th percentile of allowed amounts, and then to CMS. What's interesting here is you may notice when we get to the other slide, now this is an emergency room visit, and look at the CMS rate, really, and the allowed rate. This is where it's interesting. So if you'll see here, this is a 25-minute typical office visit. You'll notice that the CMS rate is higher for the office visit than the ER visit. Again, that reflects, and as people know, Medicare is a policy-based fee schedule that tries to encourage certain types of services. You can agree or disagree with those policies, but it's not necessarily even purporting to reflect the costs in the market per se, as much as advancing certain interests or dealing with certain budgetary constraints. So it's not so unusual to see a primary care visit being advanced by CMS at a higher amount than an ER, because they try to encourage more primary care maintenance. What is fascinating in Oregon is that even the allowed negotiated amount for the typical office visit is higher for this than for the ER visit. That you don't typically see. Usually the allowed amounts negotiated by the private payers would still be higher and reflect the ER visit. Here, what we sometimes are asked to do, because as mentioned, there's changing venues of care, there are same services being rendered at these different types of venues, people often want to see cost comparisons. So here's just an example of the types of studies that we do. Here we've taken 3 geozips in Oregon, comparing it to the state as a whole, comparing it to the nation. Again, you can see the hierarchy. This is at the median charge amount. So again, these types of visualizations can be quite telling and allow people to really advance decisions. This is another situation where we're comparing a 15-minute office visit And again, this is where Oregon is very unusual, distinct from most of our states. You could see that when we compare office visits to urgent care to retail clinics, usually urgent care have the highest charges reflected. And you can see that in the nation. That national sort of array is what we would typically see in most states. It's interesting that in Oregon, the office visit is ranked higher than the regular urgent care visit. Finally, just wanted to turn to opioid use and abuse. We've done a lot of work in this area. We've done 4 white papers that are freely available on our website. The last one we did was take all 50 states and isolate the most frequently performed treatments and protocols for opioid use and abuse, and the top 5 most expensive cost centers associated with these treatments. Again, what was shown, and we're not going to show you 50 states, we're just going to show you 3. But if you looked at all 50 states, it would be like a very vivid tapestry, because everyone is often going in different directions and incurring different levels of cost. Here we've just taken Oregon, Washington, and Nevada, and you can see where it's the same color, it means it's the same procedure, and where it's white, it means there's no match. Again, in Oregon and Washington, interesting, you both have methadone maintenance or methadone administration as the top most frequently utilized code. And so there's less dissimilarity between these 3 states that we usually see around the country, but you start seeing that variation as we start getting into the top cost centers. And what's also interesting about Oregon compared to other states, and it's even true with Washington and Nevada, is there's only 1 drug test in the Oregon column. Usually around the country, drug testing is really becoming sort of the top cost centers. And there's some question whether they're being overused and too frequently administered. It's interesting whether Oregon may be on the other side. I know there have been some good work in the state with Oregon Recovers and statewide coalitions and attempts to really bring a focus and attention to the treatment of substance abuse. And one of the things, if you're trying to test to see if someone's continuing in their recovery, is to do some drug testing to see if they're adhering to their protocols. Interesting, Oregon only has the 1. And then when you go to the allowed amount differences for the top utilized codes, you can begin to see how varied it is, how differently states are really incurring costs. And these are the negotiated amounts for the top 3 most highly performed services. And here are the negotiated amount differences, again, showing different states are really moving in totally different directions. And what's fascinating, we often get asked when we showed that white paper with this 50-state tapestry, like what's working? And the question is, are people looking over the fence at their neighboring states to try to understand what is working? Because we see intensive outpatient, group psychotherapy, partial hospitalization, all different kinds of services, naltrexone, methadone. So it's been a fascinating sort of study to wrap our arms around. And the next step is we would love to follow cohorts in those different protocols to see what may be working. Thank you.
Let me ask first, other states where young people might go injure themselves more often, I guess I was really struck by let me stop and say this differently. I was really struck by how prominently young people are presenting in your data, whether it's through mental health, through telehealth, through urgent care or sprains and activity-related diagnoses. What do you think? What are those demographic and generational shifts looking like when you think about this across the country?
There are a lot of factors at play, I think. What we're seeing is for those really almost like 35 and under who don't have a long-standing relationship with a primary care physician, you're seeing a real openness and a real need for convenience to access care when they need it. One thing that's, whether it's concerning or not, I think it depends on your point of view. It didn't show up in Oregon, but probably if we went down a few diagnoses, it would. You're starting to see a lot of chronic conditions appear as the diagnostic reason for why people are going to urgent care centers. Again, I think that a lot of people are either working unconventional hours or really feel like they may be having trouble getting an appointment when they need it, and are going with chronic respiratory issues and other kinds of conditions. So it's moving away from that sense of one step down from the ER. So I think that, that's one factor at play. I think what we see that's concerning in the data really go to the 22 and under population in terms of behavioral health. I mean, I think we're all reading the same studies. What impact is social media having in terms of depression and different kinds of ADHD and other disorders? And on the other hand, you can look at it through the other lens with increased insurance, access to insurance. The fact that we're seeing claims, at least it means people are trying to access treatment. And to look at that, over 50% of those under 22 using telehealth for mental health reasons, it may be a very comfortable way for people to reach out for care that otherwise they would not have.
It's so crazy, the level of anxiety that you see in young kids that presents in your data and that we see in just study after study. It's a little frightening. I'm not sure what we're doing to ourselves that presents that, but does this use of telehealth, is it a generational thing? Meaning, is it going to take a generation for young people to become middle-aged people, to become elderly people, for that to transcend, that, particularly telehealth and behavioral health, to transcend across all demographic cohorts? Or do you see it shifting in some states that it doesn't exist here?
I think it's shifting quite dramatically, and you can see it in the way in which laws are changing almost in real time. We saw in Texas, you may recall, DJ, just recently they passed a law that liberalized their use of telehealth. In the beginning, they had required the patient and the physician to have an in-person encounter before you can move to a telehealth relationship. And that was really suppressing telehealth utilization in the state. They lifted that, and we saw immediately the data climb. I think what you're also going to see, a lot will depend though on reimbursement practices. As new apps and technologies get developed to monitor cardiac conditions and other kinds of conditions, you're seeing a growing use of that asynchronous type of monitoring. Also, a lot of post-discharge type of compliance, people reaching out after someone leaves an acute facility, monitoring their health indices or just making sure they're adhering to certain protocols. So I think as technology moves, the telemedicine is also moving in that sort of asynchronous model. Also, with more insurance available to people, access is an issue. There are states that are really challenged for having primary care outlets, while retail clinics, and now we're seeing urgent care filling some of that void. Telemedicine is becoming a necessary sort of foot soldier in that.
Questions from you all in the audience? We see one hand up here. Got a microphone coming behind you, sir. Why don't you tell us your name and your organizational affiliation and go ahead and ask your question.
Good morning. My name is Tim Powell. I'm the CEO of Evergreen Family Medicine in Roseburg. I appreciate Fair Health's commitment to transparency. I will say our insurance industry is anything but. One of the private attempts to make it much more transparent is the direct care model. In that you have a very defined level of services, and you have a very precise cost that is extremely transparent. It has to define itself as not an insurance model. At least in Oregon, it's somewhat hostile to that because of the insurance influence. But do you have data on that for us? Because consumers and well-minded providers are trying to figure this out, and they're not getting a lot of help from government and insurance.
Great question.
Right. So Fair Health can only report out what comes in on a claim. So if there's a claim associated with it, we can track it. So even if it's a capitated model, for example, even with capitation, we still often get a claim to show and be able to track utilization. But if this is something that is outside the insurance model altogether, unfortunately, that would not come to our attention.
Question back here, great.
Hi, my name is Angel Prater, and I'm an executive director of a nonprofit called Folk Time, and we're a consumer-run, peer-run organization here in Oregon. So I love data. So I'm wondering, from the behavioral health perspective, I'm not seeing any kind of data around the utilization of individuals with lived experience to provide that social component, that ongoing, long-term supportive support for addictions, mental health, et cetera. And I'm wondering if you all are beginning to or have been tracking data in that area, because it's something that I feel extremely passionate about, to ensure that we're looking at prevention from the eyes of the people who've been there, and having individuals as a mutual member of all health system teams, because we are evidence-based as well, and we are able to show cost reduction, reallocation, reduction in recidivism, et cetera. So I'm just curious if you're looking at that data, and if so, are we able to access that? And if not, may I help? Thank you.
So in answer to your question, which is an excellent one, there are two things that we are, a study that we designed that we are now speaking to some foundations about. And we also work with Dr. Marty McCary. I'm not sure if you're familiar with him, from Johns Hopkins, who just wrote a fabulous book about the healthcare system, the price we pay, and has focused a lot on the opioid crisis. The two things we're looking at is retrospectively and prospectively. So we have longitudinal data. We can isolate those people who have a substance use disorder. We would like to look backwards to see how many are coming out of surgeries, how many really have comorbidities with behavioral health, mental health issues. Are there profiles that could be identified, to your point, that could really lead to more prevention? Then looking prospectively, tracking those patients who are down a certain path, whether it's group psychotherapy, whether it's methadone maintenance, naltrexone, to see who's relapsing, who's returning to the emergency room, who's having an overdose, to start trying to look at some evidence-based factors that would steer public health officials and other professionals to really focus on one maybe over another, to start looking at the value proposition of some of those, as well as tracking costs associated with each of the different services.
One of the areas that I feel passionate about are the social aspects, social change, and how we are with people, not just what we're doing. And what I'm seeing, I've been in this field for 23 years, and what I'm seeing is that we're pathologizing from a medical lens. That's the dominant culture, right? And so how do we fill in the gaps from the social sector, the social justice, the social change piece that's lacking within our whole health system? And so that's where I would like to see more effort put into that prevention, to allow for that social aspect, which is one of Maslow's hierarchy of needs. So thank you.
No, and just 2 points. One, we're starting to see more social determinants coded on claims, which we are tracking. But separately, we do what we can do within the universe of claims we have. We are always, and do, hand the baton to others with data cuts that could then let them run with the findings we've uncovered, so they can go and really layer in richer elements. So it sounds like there may be some opportunities there.
Let me ask about pharmacy. Maybe I missed it, but are there nuggets around pharmacy that may be unique either nationally this year that are different from other years around pharmacy, maybe that apply specifically to Oregon that you just didn't have time to cover? Specifically maybe behavioral health pharmacy. Any insights that you could share there about claims and utilization?
So when the settlement was originally achieved back in 2009, prescription drugs were not part of the settlement. We have all of Part D, which is part of the Medicare program. What we do have are the specialty drugs, the subcutaneous solutions, inhalation solutions, the IV administered drugs, oncology, rheumatoid arthritis. Those we track, and those we've done some reports to state officials on to show some of the notable increases in those over short periods of time, and what new drugs are really getting diffused in the market. So that is something we track more closely. We don't have we have some prescription drug data where some contributors have recently agreed to start giving us that data, but it's not as robust as the other data that we have.
And I'm sorry, you probably said this and I missed it as well. I saw the lower utilization trend for hospitals in Oregon. A couple times you also referred to the percentage of total claims paid. Are Oregon hospitals also on a lower trend for total claims paid vis-a-vis the country? Was that data?
That was comparing actually office to urgent care to retail clinics.
Okay.
So hospitals, And then in terms of the ASC to hospital outpatients are reimbursed at a higher level. We didn't compare the utilization over time.
Right.
Who's going to the hospital versus ASCs? It's something we could easily do. We're limited.
Yeah, of course.
We would love to show everything.
Thank you. My name is Sue Hennessy, and I'm a board member at Care Oregon, retired Kaiser exec. And I'm curious about what insights you might have about the limitations of claims data, and what are the possibilities from where you sit in starting to incorporate the clinical data that's increasingly available and add it to the claims data to start to address the kinds of issues that were previously noted by our questioner. Do you have insights that you could offer there?
Well, I think what we have found, there are, as you know, there are all-payer claims databases that have emerged, and I know Oregon has one as well. What has been helpful at Fair Health, because there are so many differences in the way in which certain claims are coded and presented and mapped, to be able to nationalize and standardize that mapping across the country has enabled at least us to be able to tell a story and create comparisons that are otherwise difficult when you're plugging into different types of mapping approaches and different kinds of formats. So I would say there's great value in having that type of leveling and standardization, to the extent that you can, and claims data itself tell a story, but they don't tell the whole story, right? You would know someone had a lab test, you don't know what that A1C result is, and that's where the clinical information comes in. And so we are obviously intrigued and always explore ways in which we could be the other side of the coin to the clinical record. There are some sort of electronic health initiatives going on in certain states that we've already talked to certain individuals about, plugging in our information to the electronic health record from the patient perspective, so they can get access to cost information, but also that we could perhaps get de-identified information as well to start enriching what we have. Oftentimes we'll make data available to clinical systems. They know their patients, so we can give them some insights about whether their patients have left their health system to go elsewhere for services, and they can then start looking at what that impact has been on their medical record, for example. Have they suffered as a result?
Let's give her a round of applause. Robin Gelburd from Fair Health. Thank you. Great stuff.